The House Health Policy Committee will come to order. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett.
Here.
Carter.
Here.
Hadsma. Here. Neely.
Here.
Glanville.
Here.
Kofia.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingans.
Here.
Vanderwall.
Present.
Filler. Mueller.
Here.
Van Werkum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Here.
Madam Chair, you have 18 members present, a quorum.
Thank you. Representative Cuffey moves to approve the minutes from our meeting on October 5th. Seeing no objection, the minutes are approved. First up, we will be adopting substitutes to House Bill 4504 and 4505, which would have Michigan join the Physical Therapist Licensure Compact before moving to report the bills. Then we will take up the Occupational Therapist Licensure Compact bills HB 4169 and 4170, which also have substitutes to adopt before voting to report. I will be sending House Bills 5077 and 78 to the Behavioral Health Subcommittee for their consideration. Then we will hear testimony on SB 513 from Senator McBroom to allow the Helen Newberry Joy Hospital to transfer from a county hospital to a nonprofit hospital. Finally, we will take up HB 4276, introduced by Representative Farhat, which affects pharmacy benefit managers and has an H2 which reflects negotiations since the bill was introduced. Finally, if you plan to testify on any of the bills before the committee today or have your position recorded, please fill out and submit a card to the clerk before the end of the meeting today. First up, we have House Bill 4504 and 4505. We heard testimony on these bills to enter Michigan into the Physical Therapy Licensure Compact, and we do have some cards to read in. Economic Alliance for Michigan supports 4504, 4505, 4169, and 4170. HCAM supports 4504 and 4505. Lara opposes 4504 and 4505, and Michigan Nurses Association opposes 4504 and 4505. Representative Glanville moves to adopt the H1 sub to HB 4504. Mr. Clerk, please take the vote.
On the motion to adopt, Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kofia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Werkum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, no nays, no pass. The substitute for 4504 is adopted.
Representative Conlon moves to report out HB 4504 with recommendation as substitute H1. Mr. Clerk, please take the vote.
On the motion to report, Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kofia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Werkum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, no nays, no pass. House Bill 4504 reported as substitute H1.
Representative Thompson moves to adopt the H1 substitute to HB 4505. Mr. Clerk, please take the vote.
On the motion to adopt, Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kofia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Werkum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, no nays, no pass. The substitute is adopted.
Representative Schmaltz moves to report HB 4505 with recommendation as substitute H1. Mr. Clerk, please take the vote.
On the motion to report, Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kofia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yep.
Filler.
Yes.
I'm sorry. Thank you, Filler. Miller.
Yes.
Wait your turn.
Reingans.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Werkum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, no nays, no pass. This House Bill 4505 is reported with recommendation.
Thank you for joining us, Representative Filler. Next, we will take up the Occupational Therapy Licensure Compact Bills HB 4169 and 4170. We do have a substitute H1 for both bills, and these substitutes do the same as the ones we just adopted for the previous bills and delay implementation for 90 days. We do have cards to read in. Thank you. HCAM supports 4169 and 4170. Lara opposes 4169 and 4170. And Michigan Nurses Association opposes 4169, 4170. Representative Neely moves to adopt the H1 substitute to HB 4169. Mr. Clerk, please take the vote.
On the motion to adopt the substitute, Chair Rogers.
Yes.
Representatives Witset,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kofia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Werkum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, no nays, no pass. The substitute is adopted.
Representative Filler, glad he could join us, moves to adopt the H1 substitute to HB 4170. Mr. Clerk, please take the vote.
On the motion to adopt the substitute to House Bill 4170, Chair Rogers.
Hold on one
We
second.
didn't report.
Yep. Representative Fitzgerald moves to report HB 4169 with recommendation as substitute H1. I apologize. Mr. Clerk, please take the
On the
vote.
motion to report House Bill 4169, Chair Rogers.
Yes.
Representatives Witset,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kofia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Werkum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, no nays, no pass. House Bill 4169 reported with recommendation of substitute H1.
Representative Filler just wanted his name said a couple extra times. Representative Filler now moves to adopt the H1 substitute HB 4170. Mr. Clerk, please take the vote.
On the motion to adopt, Chair Rogers.
Yes.
Representatives Witset,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kofia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Werkum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, no nays, no pass. The substitute is adopted.
Representative Roth moves to report HB 4170 with recommendation as substitute H1. Mr. Clerk, please take the
On
vote.
the motion to report, Chair Rogers.
Yes.
Representatives Witset,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kofia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Werkum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, no nays, no pass. House Bill 4170 reported as substitute H1.
House Bills 5077 and 78 were introduced and referred to the Committee on Health Policy. It is my intention to have Chair Braybeck and the Behavioral Health Subcommittee work on these bills. Mr. Clerk, please read in the provided letter.
A letter dated October 12, 2023. Dear Mr. Clerk, on October 3, 2023, House Bills 5077 and 5078 were referred to the House Committee on Health Policy. These bills give employees of agencies who are already authorized to carry and administer opioid antagonists to also distribute them. I am asking the Subcommittee on Behavioral Health to review and make recommendations to these bills. Addressing the opioid crisis and preventing overdoses and death is a priority. I am confident that the subcommittee will be successful and productive. Sincerely, Julie M. Rogers, Chair, House Committee on Health Policy.
Thank you. Go ahead, Ease, call the chair. Committee on Health Policy will come back to order. We're going to change up things a little bit here, and next we're going to listen to testimony on HB 4276, introduced by Representative Farhat. To testify in support of the bill, we will hear from the bill sponsor, and joining us virtually, I believe we have John Cavello, Director of Government Relations for IPC, the Independent Pharmacy Cooperative, and Joel Kurtzman, Director of State Government Affairs for NPCA, the National Community Pharmacists Association. John Gross, an independent pharmacy owner. Prior to, actually, you need to come back up to vote a second, sorry. Prior to beginning testimony, we will adopt the H2 H2 substitute, which reflects negotiations that have taken place since the introduction of HB 276 and will be the version of the bill those testifying will be speaking to today. Representative Hadsma moves to adopt the H2 substitute to HB 4276. Mr. Clerk, please take the vote.
On the motion to adopt, Chair Rogers.
Yes.
Representatives Witset.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kofia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes. No, excuse me, pass. I'm sorry.
Filler.
You almost caught me off guard.
Pass.
Mueller.
Pass.
Van Werkum.
Pass.
Roth.
Pass.
Schmaltz.
Pass.
Thompson.
Pass.
Madam Chair, you have 12 yeas, no nays, 7 pass. The substitute is adopted.
All right, now Representative Farhat will be joining us. Thank you so much for bringing this bill forward, and you can begin whenever you are ready.
So thank you, Chair Rogers, members of the Health Policy Committee, and I would also like to thank Representative Filler for being here today. Before before us today is House Bill 4276. The legislation seeks to codify the practice that DHHS has entered into with its Medicaid pharmacies. We've seen that in the past, Medicaid pharmacies specifically have struggled to be opened in difficult-to-service areas. And it's caused a severe access to care issue that in years past led to patients either having to prolong or go out of their way to find a pharmacy that could treat them, or in some cases they would be forced into non-local alternatives. What the department did several years ago was they entered into a very simple formula, and they asked that the PBMs and the plans that contract with them reimburse at a model that was NADAC, and NADAC was one of the metrics they used, the lesser of 3 reimbursement forms, which is NADAC, wholesale acquisition cost, usual and customary, and the lesser of the 3 prices. And they said essentially, we're going to pay you at, and I'll equivocate a little bit, we'll pay you at cost, but we're going to give you a dispensing fee to cover, the actual labor and the utilities and all the things that go into filling a prescription. And what they found is that model really led to better patient access to care, and it's led to a higher level of cost savings for the state. House Fiscal actually in their analysis claims that the state can save anywhere from $5 to $12 million in the proposed legislation that's in front of us today. We've worked closely with the department in making sure that it reflects what they want to see in the pharmacy space, especially as it pertains to Medicaid. And we've also made sure that there's safeguards there for them to remain flexible if they need to be. I look forward to taking questions, and I'm excited to have some folks here to testify more about how this legislation impacts the pharmacy market in Michigan and how it makes us a more competitive state.
Thank you, colleagues. Does anyone have a question right now for Rep. Farhat? Otherwise, we can wait till the end for testimony. Wonderful. Thank you. Joining us on Zoom, I think, we have John Cavello, Director of Government Relations for the Independent Pharmacy Cooperative. Welcome, and begin whenever you're ready.
Thank you, Madam Chair. My name is John Cavello. I'm the Government Relations Director for the Independent Pharmacy Cooperative. We're the largest buying group for independent pharmacies in the country. We have close to 400 stores just in the state of Michigan. And I appreciate you being able to accommodate my schedule to do this remotely rather than me being able to get to Lansing today. I hope you have my written statement, as well as 3 background materials for education on the policy development of these reforms throughout the country. So that is for the benefit of all members of the committee. I won't take up the committee's time by reading my testimony, but I want to focus on a couple of key areas for the committee to consider as you move this bill. First of all, I want to thank you for bringing this up and really applaud Michigan. Starting back as early as 2019, you were in the vanguard of states identifying this as a policy problem. The history of this is after the passing of the Affordable Care Act, there was a big push for states to carve in their pharmacy benefit and Medicaid into managed care under the promise of what proponents said would save money and create efficiencies in the system. Well, over the course of the past 10 years, the evidence and the data from states' own analysis, not from our industry's analysis, has demonstrated that this has actually cost states over $1 billion through a practice called spread pricing, where essentially the PBMs for MCOs have overcharged the states more for the cost of what they claim was the prescription benefit than was actually paid in the benefit to the pharmacy. Michigan, obviously through the appropriations process, solved this early on in fiscal year 2020 Appropriation Act. You followed a pattern of a problem that your neighbor in Ohio started, but you've seen the evidence by doing this fix. You've saved money. I appreciate what the fiscal note is saying under the current system of making this permanent. But I would point back to the 2 reports the legislature mandated that Michigan's Medicaid department report to them on the last 2 years of the prior program, when there was no oversight and no mandates to require cost-through, transparent pass-through of the total, just the overall cost plus an administrative fee for this benefit. And Michigan Medicaid is coming up with figures that's close to $750 million over 2 years, of which they were overbilled. That's a pattern that 12 other states are experiencing, and there have been 17 states that have studied this, and almost all of the 35 Medicaid states that had carve-ins are moving or have implemented reforms. So all you're really doing is putting in place the policy outcome as a permanent part of statute that's already been proven by your 2.5 years of using this methodology. The other thing I wanted to point out too, because I know you will probably hear from the other side, well, this will raise costs. Clearly, your fiscal analysis is showing otherwise, because they only look at the increase in the dispensing fee. What they'll never tell you is this has done away with all these overbilling practices, charging more than what they pay us, clawing back money at the end, hidden fees, all things that have been discovered in all these other states. And that all went away under this program, in addition to what you've gotten with the preferred drug list giving you enhanced rebates. It certainly is time for you to make this permanent based on the evidence that shows your policy is working. The other evidence I can point to that's in the paper I gave you, 17 states have settled Medicaid fraud cases against one PBM, one MCO, Centene, for their admitted overbilling of state Medicaid programs of their prescription drug benefit. More settlements are going to be coming. And the federal Congress right now is as a part of their PBM review, looking to seriously move legislation that will put an end to this practice that at the federal level, they've booked to save $1 billion over 10 years. So this is really for a win-win-win. It's a win for the state taxpayers. It's a win for the patients because they will be able to get their pharmacies to cover and provide them all their prescription drug benefit needs. And it's a win for their provider community being able to stay invested in these communities and serve these vulnerable populations. You've helped put through annual actions an end to a problem that's occurring all across the country. And I applaud this committee to move this bill and make this permanent. I will point out we've also asked for one technical amendment in my testimony to ensure this encapsulates by referencing all of the Public Act from 2020 language on this mandate in the Appropriation Act. I realize you already moved your amendments, but look forward to working through that through the rest of the legislative process. And I'm happy to answer any questions anybody has on Michigan or the trends in other states after you hear from my colleague Joel Kurzman from National Community Pharmacy Association.
Do we have any questions from committee members? Representative Reingans.
Thank you, for Madam Chair. Question is kind of a compare contrast. So instead of codifying this boilerplate, we could just carve our pharmacy benefit back into fee for service. So can you explain why it's better to codify this in our state law instead of put this into fee for service?
Thank you for the question, Representative. Just for the benefit of everybody who may not have known the history, in 2019, that was one of the approaches looked at by the executive branch in their drug affordability task force review. I think there were impediments that were discovered in the process of doing that that process was not chosen as the path forward. And we've seen it approached and reviewed in several states. This method gets you to the same result, which is you have a preferred drug list, you are controlling and mandating and have review and oversight of getting all those rebate dollars to spend on your state Medicaid program. What this gives you that different than the carve out is you're putting the mandating contract for oversight and accountability back to you, that you are only paying for the true cost of the prescription drug benefit without taking on the administration work of managing yourself. Candidly, Representative, that's a policy choice for the administration and the legislature. You've gone to the same net result that has benefited everybody in this, including Michigan taxpayers, that you now are only paying for the true cost of providing prescription drug benefits in the Medicaid managed care program. So I hope that answers your question.
Thank you. Anyone else? Okay. Thank you so much for joining us. Next, we have Joel Kurtzman, Director of State Government Affairs for the National Community Pharmacists Association, also joining us on Zoom. Welcome, and begin whenever you are ready.
Yeah, thank you so much. It's a pleasure to be with you, and Madam Chair and members of the committee. Good morning. I'm Joel Kurzman, and I serve as Director of State Government Affairs for NCPA, the National Community Pharmacists Association. We appreciate the chance to speak with you in support of House Bill 4276, legislation, as you know, that moves pharmacy reimbursement methodology from the budget boilerplate into statute in Act 280 of 1939, the Social Welfare Act. Just quickly about NCPA, we represent the interests of America's community pharmacists, including the owners of more than 19,400 independent community pharmacies across the country, and more than 800 in the state of Michigan. Pharmacies are the most accessible healthcare providers in the nation, and independent pharmacies play a unique role in our healthcare ecosystem. They're often the only access point to healthcare in rural communities and often fill voids that we've now termed to be pharmacy deserts in both urban and rural areas. And these are often impacting people of color and other minorities disproportionately. Independent community pharmacy owners are also real active in their communities. We're involved in public health, civic, and volunteer projects in our neighborhoods. So we believe that moving the pharmacy reimbursement into statute makes permanent the wise changes that were legislated in 2020. This will ensure greater stability to the independent community pharmacies that serve patients in Michigan. And as John spoke to earlier, Michigan is just one of 10 states to create this reimbursement floor in its managed Medicaid program using fee-for-service methodology. And by doing this, Michigan is avoiding spread pricing, as John mentioned, that can cost millions of dollars. And in the written materials that I've submitted in advance of testifying here today, we have citations for where in the state of Ohio, Kentucky, and some other states, the state-funded benefit plans have been severely overcharged. And, you know, John stole my thunder on mentioning that the CBO has seen savings, or would estimate savings of nearly $1 billion if these types of reimbursement transparency policies were put in place across the country. But just in short, Michigan has effective public policy in place right now that benefits both patients and the local independent pharmacies on whom they rely. And so we think that this policy should be codified, and we urge you to advance this important legislation. We want to thank Representative Farhat for his leadership on this bill. And again, thank you for your time this morning. I'm happy to take any questions you may have.
Thank you. Minority Vice Chair Vanderwall.
Thank you, Madam Chair. And Joel, thank you for being here. I always appreciate the information you share. You know, as I read through, and maybe this could go directly to the bill's sponsor too, but I think you can probably answer that. Why did we pick a number of 7 pharmacies? I know that in my district, I have what I consider independent pharmacies that have more than 7 retail facilities or pharmacies located through several different counties, why, if they fall into an independent pharmacist or a pharmacy, why don't we just expand that number into the entire group?
Yeah, pleasure to take your question, and it's a very good question. I would actually defer it to stakeholders on the ground in Michigan who negotiated the legislation. You
That's
know,
fine.
I'll,
We
I'll
can.
just say as a point of reference, you know, our membership is included in most cases under the 7 store figure, but it's a fair question because from an intellectual perspective, if there are savings accrued in this format, perhaps there would be additional savings if the policy applied more widely. So it's a good line of questioning. I just don't have the specific answers as to what came up with the number 7.
Thank you.
Thank you, Representative Farhat. Would you like to respond?
Yeah, I'll say I'll just say that for us 7, that was the boilerplate. That was why we decided to keep the codification revenue neutral. Or in this case now, after the fiscal analysis, it'll save us some money, but it would still not have a fiscal impact into next year.
Very good.
Yeah.
Thank you.
Thank you.
Any other questions? And I have the question about Representative Farhat. You just talked about save us money, and it looked like the fiscal analysis was quite favorable. Could you comment on that?
Yeah, so using the lesser than model has proven to be really beneficial for the state, as it keeps us flexible and able to, again, if it's cheaper on NADAC or wholesale acquisition cost or whatever it might be, paying the lesser of the 3 costs keeps the formula and keeps this model competitive and flexible enough to adjust with market rates, while also not having to see any inflated prices that we're paying for any administrative fees. And another thing too is that because of that, we're going to be saving around $6 to $12 million according to the state House Fiscal Analysis, which will be a huge cost savings for us, especially as we're trying to bring down prescription drug costs.
Thank you. Any other questions from members? Thank you so much. We appreciate your testimony.
Thank you.
Next, we're going to switch over to Senator McBroom's bill, which is SB 513, and I believe he's still caught up voting. Oh, do we have one more? Tom, nope. Joel Kurtzman? John Gross. I'm sorry yes, that is in my script. Come on up. John Gross is an independent pharmacy owner, and I apologize that I skipped over you. Welcome and begin whenever you're ready.
Thank you. Thank you, Chair and Committee, for letting me speak for a moment. By the way, I'll be meeting Joel down in the annual convention for NCPA this weekend. I happen to serve on the State Legislation Committee, so matters like this are on the committee yearly. So my name is John Gross, and I'm an independent pharmacy owner. I'm a pharmacist from Fair State University. I own 5 pharmacies, 3 of them in Clare County and 2 of them in Genesee County. And I'm here today to support House Bill 4276. Also, I'm a member of the American Pharmacies and also Executive Director for the Michigan Independent Pharmacy Association, representing over 200 pharmacies. This codifying this was something that's been on our radar for a long time, and I really appreciate having this come in, something that we can put into legislation. Going all the way back to 2017, personally, I was a pharmacist working at my own store and running into issues. It was probably the fall when I'm looking and seeing what I was getting reimbursed for my managed care Medicaid plans. And in Clare County, where I have 3 of the 7 pharmacies in the county, I was at the time getting reimbursed what's called a MAC price, which is whatever the pharmacy benefit manager wants to pay me, plus a dispensing fee of anywhere from 5 to 30 cents. And that 5 to 30 cents doesn't even cover the vial and the cap that I have to put that medication in. And so by allowing this language here, which is mimicking the fee-for-service, the NADAC plus the cost to dispense, and being able to get paid a dispensing fee based on actual cost to dispense the medication on a survey that was done for pharmacies in Michigan back in 2016, literally allowed me to stay in business. Unfortunately, some of my colleagues weren't able to survive that long, and were affected by it and went out of business, so to speak, which has caused some patient access in certain areas. In Clare County, we have about 30% Medicaid patients. My stores run around 30 to 40% Medicaid claims, and this language that is in the boilerplate that we're looking to have codified was a lifesaver. And quite frankly, the reason for putting this in legislation is if for some reason, some year, fiscally, this was to be eliminated, I would be out of business. And a number of my colleagues from around the state would be in the same boat. In a couple of my communities, there's just me and a chain store, and some of those chain stores don't even take some of the Medicaid managed care plans. I can give an example. In Beaverton, Michigan, the store, they closed up last year, and the only other pharmacy there is a Rite Aid, and Rite Aid doesn't take the Meridian plan. So those patients that have Meridian for their Medicaid health plan have to drive to Gladwin or to Clare or to Coleman and outside as far as patient access goes. And I know that there's Walgreens and Clare and my Gateway Pharmacy store are the only two stores in Clare. And for the longest time, Walgreens never took or doesn't take Molina, which is half of the patients that have Medicaid in Clare County. And that was part of what was driving me out of business, where I had all of the Molina patients coming into my store where I'm basically subsidizing the prescription plan because I'm getting paid sometimes the cost or less for the drug and then an extra 5 to 30 cents for a dispensing fee. And so that led to me coming down to Lansing back in 2017 and talking with the department about what was going on here. And also when they talk about the where was I? Coming down here and talking about the spread pricing that was going on. I literally had the department audit my pharmacy to take a look at what was being paid for, what I was getting paid compared to what the plans were getting paid. And that was something that was instrumental. At the same time, Ohio had done a study and found out that plans were getting paid, the Medicaid plans were getting paid $200 million more than what the pharmacies were getting paid. And so they eliminated that there. So having this language in, again, shows that there is a savings for what's going on, and where it's more of an objectional pricing instead of a subjectional, where the plans can just kind of pay us whatever they want. So I am in support of that, and if there's any questions, I'll be happy to answer those.
Thank you. Do we have any questions? Representative Hadsma.
Thank you, Mr. Gross. You indicated that if this weren't codified and if the fiscal support you have now were not continued in some future time, you'd probably be out of business in some of your Clare or Genesee County locations. Could you explain why?
Sure. 40% of my business where I don't make any money or lose money, I can't pay the bills. Why this was so passionate for me way back then was because I was going out of business. Maxed out my credit lines, borrowing money, just trying to keep my business afloat, trying to get at least a decent reimbursement on these plans. Now, if it's a pharmacy that doesn't have very much Medicaid percentage of their business, it's not as affected as areas that have 80, 90%. I've talked with pharmacy owners. Some of their stores, they had to close up 90%. You can't stay alive. You can't give prescriptions away when it costs $10 to $11 per prescription, according to the cost to dispense study, which was accurate with my stores when I had one done for my stores, and also NCPA had done a national study. The cost to dispense is $10 to $12. And by the way, that's 2016, 2017 numbers. I'm paying 50% more to keep pharmacy techs in my store since COVID happened. And I'm not, the insurance companies aren't paying anymore. They're paying less over the years. So it's pharmacy deserts. I can name, well, I won't name them, but I know a number of stores that are contemplating whether they're going to be able to stay open or not. And I can name a few that have closed in the last year or so. So the patient access is a real issue. Like was mentioned earlier, as far as the pharmacists, we are on the whole drug supply chain, the pharmacist is the one that the patient has the contact with. It's our relationships with our patients that we have in those communities. Michigan happens to be number 5 on the list of number of independent pharmacies across the nation, behind California, Texas, New York, and Florida. We have over 1,000 independents. So in your districts, you have independent pharmacies that patients rely on. And if they have any appreciable amount of Medicaid claims that they're billing, and this reimbursement goes away, then that puts a fiscal financial responsibility or problem on that store.
Any other questions? Thank you. I appreciate everyone's testimony. We do have a few cards to read in. Supporting HB 4276, Michigan Pharmacists Association. We have 2 cards of support from AAPA, the Arab American Pharmacists Association. Michigan Nurses Association supporting the bill, and DHHS is neutral on the bill. Welcome, Senator McBroom. I'm glad you could join us. Come on up and we will hear testimony on his bill, Senate Bill 513. And we also have Hunter Nosrint, CEO of Helen Newberry Joy Hospital, joining us remotely. Begin whenever you're ready.
Thank you, Madam Chair. Thank you, members of the committee, for taking time to look at Senate Bill 513 today. I'm sorry if I've kept you waiting. The Senate just completed a session. As you probably know, the Upper Peninsula is quite remote in many places, and so hospitals are few and far between. The hospital at Newberry is one of our most isolated facilities, being more than 100 miles from the main hospital in Marquette to its west. And so it's a very critical need there. And currently the structure that hospital is, the law that hospital is structured under, restricts it from offering some specific services. So we are asking in 513 to provide the County Board of Commissioners the opportunity to change that structure of the hospital into a full nonprofit hospital. This would allow them to have some additional options in the services they provide to our citizens, particularly in the way of pharmacy care and medical equipment care. It's a fairly simple bill, and it does allow the local community to still have the final choice in whether this happens or not. To provide any additional information, Hunter Nostrant, as you mentioned, is on Zoom. He's the CEO of the hospital and can provide much better details than I can.
Thank you. I think we'll hold questions to the end, so go ahead, Hunter. Begin whenever you're ready.
Thank you, Madam Chair and members of the committee, for your willingness to hear us on Senate Bill 513. As Senator McBroom said, fairly simple bill. I know we've talked to many of you before. I want to be efficient with your time, but I'd also like to provide, again, an overview of Helen Newberry Joy Hospital. H&JH has been serving Lewis County and the surrounding communities since 1965. We're located in the center of the Eastern Upper Peninsula, and we're a DMV accredited critical access hospital, and we're licensed for 25 beds. We provide a wide range of ancillary outpatient services along with surgical services, and we also have 4 rural health clinics, our largest one residing in our main campus here in Newberry, and we have 3 others located through the outlying communities throughout the Eastern Upper Peninsula. These rural health clinics offer primary care, a wide variety of specialists, and some same-day clinic appointments. In addition, we also have an attached 39-bed long-term care facility that provides quality care for our community residents. And as Senator McBroom had alluded to, Newberry Joy Hospital originally formed as a county hospital, and since we've transitioned to a Public Act 230. We did that back in 1989. And we're one of the few hospitals remaining under this Public Act 230, and being organized under the statute presents challenges in responding to the rapidly changing healthcare landscape. This bill would allow us to transition to a more traditional not-for-profit corporation, a 501c3, like you'd see in many other hospital corporate structures. Making this transition will allow us to react to potential business development opportunities or enter into other arrangements, the ability to improve care and provide more care to our communities, which includes expanding services outside the traditional hospital setting. If this does go and change, it could create an unsustainable business model, which would present a liability to the taxpayers of Lewis County. But the bill also retains an important protection, as Senator McBroom had mentioned, for our local control, as this conversion is still contingent upon the vote of our county commissioners, in addition to the approval of our hospital board of trustees. We appreciate your consideration of this legislation to help bring added flexibility to Helen Newberry Joy Hospital, to changing healthcare landscape, and help position ourselves to better serve the people of Luce County and the surrounding areas long into the future. I appreciate the opportunity you've given me today to allow me to speak to you, and I'm more than happy to answer any questions that you may have.
Thank you very much. We do have a question from Representative Rankins.
Thank you. Would you maintain eligibility for dish payments under this conversion?
We would.
Okay, thank you.
Any other members? I have a question. Have you had any informal dialogue with the Board of Commissioners in that county? And do you have any kind of sense of if they're open to this?
Yes, I've been able to speak with the majority of our county commissioners because this bill is actually carried forward from last session, and I was able to talk to all of them. We've had some movement with our county Board of Commissioners, so I've not been able to connect with all of them recently, but the ones who I've talked to have been very supportive of this. Our hospital Board of Trustees is very supportive of this initiative, mostly because of that liability component, where that all the liabilities for the hospital, if there's a solvency issue, would rely on the county and would really be devastating to our county. And then also they're always promoting the flexibility that as a small independent rural hospital, our independence is very important and our financial solvency is extremely important to maintain that independence. And so this will hopefully open us up to be able to continue with that financial solvency moving forward.
Thank you very much. Seeing no other questions, we'll close it out. I just want to thank you again for testifying, as well as to Senator McBroom. Access to hospitals is, of course, near and dear to my heart, so I really appreciate your testimony. We do have a couple of cards to read in supporting the bill: Upper Peninsula Health Plan, as well as Michigan Health and Hospital Association. Thanks to everyone who did testify today. I do intend to move these two bills that we heard in testimony soon, so please reach out to the bill sponsors in my office if you have any other concerns or questions. And there being no further business before the committee will stand adjourned.